Excellent. Okay, so as Jeremy says, I'm going to speak to you about pharmacokinetics. And the initial topic title was how it relates to antibiotic stewardship. But really, I mean, the purpose of this talk is to speak about pharmacokinetics as it relates to antimicrobial prescribing, or in fact, prescribing any drug in medicine. But I'm going to focus on antimicrobials because that's our shared interest. And just to kind of start off, to try and make the argument laid out, or said that I would try and convince you of in the beginning, I'm going to do that in the first slide. And that is, we believe, I think, that infections are undesirable. We also think that antimicrobials are useful for treating infections, and we apply antibiotic stewardship to improve infection outcome. Therefore, antibiotic stewardship and antibiotic prescribing, and actually our job, depends on knowledge of antimicrobial pharmacokinetics. And I've put in small brackets there, pharmacodynamics, which I will define and explain, but I'm not going to speak about in this talk because it's a completely separate area. So really the focus is going to be on PK and sources of what's called variability in drug pharmacokinetics. So what are the factors that influence drug exposure after we prescribe it and the patient takes it? And so really this is the framework. We prescribe a drug and we hope that the patient gets better, right? And antibiotic stewardship, antimicrobial stewardship, aims to optimize this process. And what is the process? Well, there's two main things that are required. One is that the antimicrobial needs to get to where the infection is, which I'll call here the active site. And then once the antimicrobial gets to the active site, it needs to kill the infection, be active against it, and at the same time mustn't be too toxic. So in the top half is the process of what we call pharmacokinetics. So when you prescribe a drug, the drug is dosed, the patient has to swallow it or receive it through some form or route of administration. The drug then needs to be absorbed, needs to distribute around the body, where after it gets distributed, it gets metabolized and then ultimately excreted. But some of the drug, after it's been given, ends up at the active site, right? And that is an input-exposure relationship over time. That's pharmacokinetics. Once it gets to the active site, it needs to have some sort of effect. And all drugs have two effects, or at least antibiotics, antimicrobials have two effects, we hope. One is that they must kill the pathogen, and we hope that that's the dominant effect. But the other effect that all antimicrobials have is that they can cause toxicity. And we want to try and ensure that the drug that gets to the active site mainly kills the pathogen and mainly doesn't kill the patient. And this is really described by a therapeutic index, which is the difference between the therapeutic effect and the toxic effect. If that therapeutic window is narrow, then the therapeutic exposure of the drug is very close to the toxic exposure of the drug, and then it's hard to dose, right? That's an exposure-response relationship. So exposure at the active site with response in terms of efficacy or toxicity over time, and that's the process of pharmacodynamics, which I'm not going to speak about because those are separate issues. But you can clearly see that they are related, because any process that's going to affect the amount of drug at the active site, pharmacokinetics, is going to affect the effects of the drug, pharmacodynamics, and so they're clearly intricately linked. So I'm going to speak only about pharmacokinetics in this talk, and this is the generic model of PK. And we need a model to understand complex processes. It's very helpful. And there's really only 4 components to a PK model, which I'm sure everyone has heard of, and I'm going to get into detail in each of these separately. Firstly, systemic absorption is required. Then the drug goes through some disposition process, which is made up of distribution from the central compartment, the compartment that we measure, which is the blood, to the rest of the body. And the second part of disposition is elimination, which is made up by metabolism, how the drug gets broken down, and excreted, how it leaves the body. And those 4 processes, the first letter of each one is ADME, and that's the ADME process. That's what PK, that's the basis for pharmacokinetics. So I'm going to go through each of these and explain with examples different causes of variability in each of these and show how it affects the way that we will think about using and dosing antibiotics. So for the first component, which is absorption, what are the factors that affect the PK? So systemic absorption is described by a term that we call bioavailability, and that is the fraction of the drug that reaches the systemic circulation. So it's, from the sites of administration, as a patient swallows or a skin patch or intravenous, to the site of measurement, which is normally almost always the blood. And clearly the bioavailability, the amount of drug that gets into the site of measurement, influences the drug exposure at that site, right? And the way that we describe drug exposure is with a measure called AUC, or the area under the concentration time curve. And you can see this equation here. I'm going to show you a few equations, but they're very simple, and I will explain them. The AUC is a function of the dose, the amount of the drug that's given, and inversely related to the amount of drug that is eliminated, and that's clearance, which I'll describe just now. But clearly you can see that this letter F, which is the symbol for bioavailability, influences the amount of drug exposure in the blood, right? So, the higher the bioavailability, the higher the amount of exposure. And this is affected, systemic absorption is affected by multiple factors, mainly related to the drug itself. So how well the drug can get dissolved, dissolution, but also physiological things like gastric emptying, which will affect the rates of absorption, not really the extent, because most drug gets absorbed in the intestine. Again, another thing that affects the rates is intestinal motility, but also membrane permeability. Again, that is related to physicochemical characteristics of the drug. So, for example, lipophilic drugs will cross membranes rapidly, and systemic absorption will therefore be perfusion limited rather than membrane limited, absorption limited. pH can also affect it, and I'll show you a very specific example just now. And then, of course, first pass metabolism, where drugs can get affected by transporters on the surface of the intestinal membrane or in the liver, or from metabolizing enzymes in the intestine and in the liver, which clearly affects the amount that gets delivered to the systemic circulation. And so first pass metabolism affects orally administered drugs rather than intravenous, because that goes directly into the systemic circulation. And clearly metabolism and first pass effects affect bioavailability. Sometimes people don't think about that. So here's an example of how bioavailability can influence overall drug exposure. And this is an example of itraconazole, the azole antifungal drug. So there's two forms of itraconazole. One is the capsule form, which is an older form of the drug, but we actually somehow still use it. These are lipophilic, and so solubility is a rate limiting step in absorption. And it's improved with food, which slows gastric emptying and allows for more time for the tablets, these capsules, to dissolve. But the dissolution and absorption of itraconazole capsules is pH dependent. And this is very elegantly shown in this trial here, where patients were given itraconazole, randomized to receive itraconazole together with H2 blocker, ranitidine, which obviously increases the pH in the stomach environment, and that clearly resulted in reduced bioavailability of the itraconazole when it was given with ranitidine, right? So you can see that the maximal concentration on the bottom here with I don't know if you can see my cursor on the bottom here with the triangle line. This is a concentration time curve, by the way. So on the y-axis is concentration, on the x-axis time. The maximal concentration achieved when it was given with ranitidine was much lower. The overall exposure, so the AUC, the area under the concentration time curve, was lower as well. But this was completely abrogated when the patients were given a cola beverage together with the ranitidine and the itraconazole. And you can see that the maximal concentration and overall exposure was exactly the same as when itraconazole was given alone without ranitidine. So clearly pH has a massive effect on the absorption and bioavailability and ultimately exposure of the itraconazole capsules, right? Recognizing this, an oral solution was formulated together with the vehicle cyclodextrin with improved bioavailability. And the bioavailability, because it was more now hydrophilic, was improved in the fasted state. And you can see I think this was a crossover study, patients who received the itraconazole solution in the fasted state in the open circles had a much higher Cmax, a much earlier time to achieving the maximal concentrations, and overall a much higher exposure with an AUC. And this is clearly beneficial for patients with systemic fungal infection who often have difficulty eating and vomiting, and therefore taking a tablet on an empty stomach is desirable. So I think this illustrates the issue of absorption very clearly. Now, what about the other factors in the PK model that I've presented? So then the next one that I want to discuss is distribution. And this is the distribution phase is the time in which the drug in tissues equilibrates with the amounts of the drug that is absorbed and goes into the plasma or the blood, right? And this is indicated by the apparent volume of distribution, which has unsurprisingly a symbol V. And the volume of distribution basically relates the concentration in the plasma or the blood to the total amount of drug that is in the body. And the total amount of drug that's in the body is actually the dose. And people kind of struggle with this concept. But I mean, basically, if you think about giving a fixed amount of a substance or putting a fixed amount of the substance into a container, if the container is small, which is the volume, the concentration will be higher for that fixed amount of drug. And if the container is big, so the volume goes up, the concentration will go down because the amount of drug or the substance that gets put into the container is constant. And so in a person, the amount of drug in a body equals the amount that is in the plasma, because that's where it gets delivered after absorption or after intravenous administration, and the amounts of drug in the tissues. And that's given by this equation. So plasma, TW, tissue water. And these symbols in the brackets are the fraction of unbound drug in the plasma and in the tissues, which is usually a constant relationship, but you can clearly see that it's multiplicative with the volume in the tissue water. And so clearly plasma binding has a very important effect on volume. Now, the total volume of plasma and tissue water together in an average 70 kilogram person is about 42 liters. And so a drug that has a volume of distribution more than 42 liters is a high volume distribution drug, and less is a low volume distribution drug. And clearly, you can see from this equation, and you can even imagine that volume of distribution is affected by binding to protein in plasma and tissues. So if the binding, say there's a very highly protein-bound drug, say 99%, and an example is ceftriaxone or bedaquiline, and the fraction that's unbound just doubles. It goes from 99 to 98% bound. So it goes from 1% to 2%. You can see that it has a massive effect on the volume of distribution. So protein binding is very important. Clearly, tissue perfusion for lipophilic drugs is important for volume of distribution, because lipophilic drugs cross membranes readily. And if there's more tissue perfusion, since critically ill patients with vasodilation, then the volume of distribution goes up, because the amount of drug that gets delivered to the tissues and the membranes crosses is higher. Similarly, for capillary leak, more drug goes into tissue water. Partition into fat and body size composition is clearly very important. So drugs that have a predilection for going into fatty tissues might have a different volume of distribution in people with different body compositions, right? So people who are fatter. And so clearly physiology very directly affects volume of distribution. And I'll show you the consequences of that in a minute. The final factor that I want to discuss before we start getting into examples of, specific examples of variability in each of these issues is clearance. And clearance relates the elimination of a drug, so the elimination rate constant times the amount of drug that is in the body, that's Ke times A, to the concentration of the drug that is in the plasma. And so it's, the amount of drug that's cleared it's drug that's cleared per volume per unit time. And clearance is made, so total elimination is made up of, as I've said earlier, metabolism and excretion. Most drugs are metabolized in the liver, so metabolism is hepatic clearance times plasma concentration, and excretion is renal clearance, because almost all drugs are cleared by the kidneys, times plasma concentration, and that makes up total elimination, which is clearly controlled by clearance. Another way of looking at it is that if we think of the total amounts of drug that's lost over time, as the dose, right? Because I mean, you can't lose more drug than you've put in over a certain amount of time, over an infinite amount of time. It has to be the dose that's lost. Then clearance must be the dose over the total exposure over that time period, which is the AUC. And clearance is affected, I think, easy to imagine from these equations, by blood flow to the liver, where it gets metabolized, or to the kidneys, where it gets excreted, clearly by intrinsic hepatocellular activity. And different drugs have something called, have different, what we call extraction ratios. So low extraction ratios in the liver for drugs like most antibiotics, actually, like beta-lactams, are not influenced by hepatic blood flow, but they're strongly influenced by changes in protein binding, because only free drug can get metabolized by metabolizing enzymes in the liver. And so as unbound drug goes up, maybe due to changes in protein binding, there could be increased clearance. And then also, of course, intrinsic organ clearance. So if there's genetic polymorphisms that affect the function of metabolizing enzymes in the liver, there could be inter-individual variability, but also importantly, drug-drug interaction. So if a drug is taken that causes an increase in metabolizing enzyme activity, then a substrate of that enzyme could be cleared more readily. Clearly, it's affected by protein binding, as I've described. An amount of renal clearance is obviously important because of excretion, tubular excretion, and then also pH. Now, I just want to speak about how this concept of half-life, which, I think people are much more comfortable and familiar with than the concept of clearance, relates to clearance. So elimination half-life, remember there's a half-life also for absorption, but I'm speaking about elimination half-life. This is a derived parameter given by this equation. And all that it means is that it's the time taken for the plasma concentration to drop by half. That's why there's this natural log 2 in here, because it's just a logarithmic function dropping by half over time. But clearly, the elimination half-life is related, as you can see this equation, to volume of distribution and clearance in an independent way. It's a derived parameter. Volume of distribution and clearance are physiological parameters. They are fixed. They're influenced by physiology, and they definitely and clearly influence the elimination half-life in this relationship. And so as clearance goes up, the elimination half-life goes down, and as volume of distribution goes up, the elimination half-life goes up. And that has implications for dosing, which I'm going to show you in a minute. So I want to now go through different physiological changes that can influence these PK parameters. And I'm going to focus on critical illness, because this is when physiological parameters change in, I guess, a known way, but also quite a radical way. And so it's a good way to illustrate how physiological changes affect PK and therefore dosing. So I'm going to first speak about the impact of increased volume of distribution. And lots of things can lead to this in people who are critically ill. So sepsis, third space fluid, surgical drains, hypoalbuminemia can all affect volume of distribution via this equation that I've already shown you. And you can see each of the parameters in the equation and imagine how they could be affected by some of these physiological conditions, pathological conditions. And so all of these things combine to increase the volume of distribution in critically ill patients with two potential effects. One is, if you look at the half-life equation, you can see that as the volume of distribution goes up, the half-life will go up, and a longer half-life leads to an increased time to achieving steady-state concentrations. And average steady-state concentration, for all intents and purposes, is the same thing as an AUC over a time period. It's just AUC is overdosing, just averaged and overlaid on top of each other. That's an average steady-state concentration. But the other effect is that the maximal concentration is reduced when the volume of distribution goes up. And you can see this equation here on the right. I showed you this already. The amount of drug equals the concentration times the volume of distribution. We're just rearranging that. So the concentration will go down as the volume of distribution goes up. This mainly affects hydrophilic antibiotics, those with a low volume of distribution to start off with in a physiological state, because you can imagine if you change those parameters, the drugs with a low volume of distribution will get affected much more than those with a high volume of distribution already. And those examples of those drugs are aminoglycosides, beta-lactams, and glycopeptides. And on this figure over here, you can really see the effect visually. This is just a theoretical drug. So again, on the left, I'm sorry, on the y-axis is concentration, on the x-axis is time. As the volume of distribution goes up, you can see that the Cmax goes down and the overall exposure goes down, but the time to achieving steady state concentration is longer, right? Because the half-life goes up. The steady state concentration is unchanged because the clearance is constant, but the time to achieving it is longer. And that's a problem in patients who have critical illness, because you want to achieve a steady state therapeutic concentration quicker in those patients because they are critically ill. And so I'm going to show you an example of this in using patient data with amikacin. So on the left is, this whole slide is from a randomized controlled trial of patients with sepsis or septic shock, about 100 patients who were randomized to 3 dosing regimens of amikacin. 15 milligrams a kilogram, which is the so-called standard dose, 25 milligrams a kilogram, or 30 milligrams a kilogram. On the left, you can see that they just confirmed that in critical illness, the volume of distribution was higher, and it was very similar between these 3 different doses, right? So in the gray shaded area is the window for the normal physiological volume of distribution for amikacin in this population, but in critical illness, it clearly goes up. And you can see that on the right, at the lower doses, the peak concentrations were much lower compared to the higher doses. In those that received the so-called standard dose of 15 milligrams a kilogram, only 39% reached a Cmax target. And those getting the higher doses clearly achieved the target concentrations much better in the context of a higher volume of distribution. And clearly that's given by this equation, which I've already shown you, that a loading dose is required, or an increased higher loading dose is required to achieve a target concentration when the volume of distribution at steady state goes up. And that's a principle. We also can apply this principle to vancomycin, where we want to use higher loading doses. Most patients that get vancomycin are seriously ill and therefore have altered physiology. And so the recommendation in guidelines is that a loading dose of 20 to 35 milligrams a kilogram using actual body weight should be given when intermittent infusions of vancomycin are used. And you can clearly see that as well on the left with, again, just a theoretical simulation. When a maintenance dose is given only, you can see the time to achieving steady state is much longer than when a loading dose is given first and then a maintenance dose is given. But ultimately, the steady state concentration is the same because clearance in this example is unchanged. Just the time to achieving steady state with the loading dose is more rapid. And on the right, you can see a simulation from patient data. This is a POP-PK analysis of patients who were using data from patients who are critically ill, simulating different loading doses, and then a continuous infusion of 35 milligrams a kilogram with vancomycin. And in this gray line, the second to top gray line, I'm not sure if you can see my cursor, the time to achieving the therapeutic vancomycin concentration of about 20 milligrams per liter is much quicker than if lower loading doses are used in the simulation, and really just supports the use of a loading dose, the theoretical use of a loading dose. Now, important to mention that the volume of distribution might not be exactly proportional to weight, right? It's relatively lower at higher body weights because at higher body weights, most of the weight is made up, in this case, it was made up by fat content, so body composition, and vancomycin is a hydrophilic drug. And so most of it will remain inside the vascular space. And so remember, at higher weights, the loading dose needs to be kind of proportionally reduced. Otherwise, you could cause toxicity. What about changes in clearance? Now, this can happen in 2 directions in patients who are critically ill. Firstly, it can increase, and that's this example here, and lots of factors can cause increased clearance in critical illness: burns, hyperdynamic circulation, patients with brain injury, different, which affects autonomic nervous system, and vasodilation, hypoalbuminemia, and clearance, which is a composite of renal clearance and hepatic clearance, is increased, mainly through augmented renal clearance. I'm going to show you the exact same equations again. So clear loading dose Clearly the half-life goes down when there's increased clearance, which leads to a lower C trough concentration. And the total exposure also goes down, given by this equation dose over clearance. And you can see that in the graph on the right, where augmented renal clearance affects both the AUC, the trough concentration, which is lower, and ultimately for drugs that have an efficacy parameter of time over MIC, less time of the drug in the range over the MIC. And again, mainly affects hydrophilic antibiotics like aminoglycosides, beta-lactams, and glycopeptides, which are excreted by the kidneys. And beta-lactams are a really good example of this because it's been confirmed in randomized controlled trials. But before I show you the randomized controlled trials, I just want to show you some PK data. On the left is a therapeutic drug monitoring study in 52 patients who were critically ill. And clearly there's an inverse relationship between the trough concentration, which is here on the y-axis, and the creatinine clearance on the x-axis. So as the creatinine clearance goes up, the trough concentration, in this case, it's a ratio of MIC in a log scale, but you can see the relationship goes down as the creatinine clearance goes up. And in this study, a creatinine clearance of more than 130 was associated with a trough concentration below the MIC in 82% of patients, so potentially subtherapeutic. On the right is just another example showing in a different way among ICU patients who got meropenem or piptaz as an extended infusion, the probability of achieving the PK/PD targets, which in this case for beta-lactams was assumed to be 100% of free time over MIC, was lower as creatinine clearance on the x-axis went up. So on the y-axis is probability of achieving this target, the axis is creatinine clearance, an inverse relationship. Now, the way to compensate for this increased clearance is to, if you're giving a drug intravenously, to increase the infusion rate, because the steady state concentration that you want to achieve is influenced by the rates of infusion and the clearance. And so when the clearance goes up, you increase the rates of infusion to maintain a target steady state. And you can see here with this simulated dosing experiment that more frequent dosing controls the extent of drug accumulation, but not the time to steady state, because in this experiment, it's assumed that volume of distribution is constant. So when the drug's given every half-life as opposed to, twice every half-life as opposed to once every half-life, the average steady state concentration is higher at a fixed clearance and a fixed volume of distribution. You can see this in patients as well. On the right, a randomized controlled trial of continuous infusion versus intermittent bolus dosing of beta-lactams in critically ill patients. And clearly in the blue box plots, which indicates continuous infusions for different antibiotics, piperacillin, meropenem, cefepime, much higher, significantly higher trough concentrations when given as a continuous infusion versus intermittent bolus. Given by this equation, again, the infusion rate just increased, goes up, and increases the steady state concentration. Now, I think this is like really beautiful translation of theory into practice, because it translates directly into improved clinical outcomes using this strategy. And these are two meta-analyses of multiple randomized controlled trials that tested continuous versus intermittent infusion of beta-lactams in patients with severe sepsis. On the left is an individual patient data meta-analysis. On the right is just a pooled aggregate data meta-analysis. They showed exactly the same thing, that there was a reduction in mortality, a relative reduction in mortality of about 30% when a continuous infusion was given versus an intermittent bolus dosing. And on the left, it was controlled for various important prognostic factors. On the right, you can see exactly the same thing highlighted in yellow, about a 30% relative reduction overall for beta-lactams. On subgroup analysis, which has enormous limitations, but just to illustrate, that's the strongest effect was for carbapenems and penicillins. Cephalosporins less so, but I think that's just because they were less well studied. Finally, I'm going to go through an example of changes in clearance in the opposite direction, so reduced clearance, which I think we recognize more often. And that really is just because of acute kidney injury in critical illness. Again, clearance is the sum of renal clearance and hepatic clearance. In critical illness, you can just add renal replacement therapy to that, because that is just the way that drugs are cleared when patients have no GFR from their intrinsic kidneys. Same equations, when clearance is lower, then half-life is longer, and that leads to a higher maximal concentration and delayed time to achieving maximal concentration. And when clearance is lower, then total exposure is clearly increased, because it just expresses the dose. And that could lead clearly to toxicity. Again, mainly affects hydrophilic antibiotics, but also partially lipophilic drugs like fluoroquinolones. You can see on the bottom right the effects of reduced clearance, so increased Cmax, decreased clearance and elimination, and increased total exposure, leading potentially to toxicity. And most of you can imagine the best example of this is vancomycin, which I'll show you in a second. The way to compensate for reduced clearance is just to give less frequent dosing. If you're using an oral antibiotic, then that's the dosing rate, which is the dose over tau, which is the dosing interval, relating clearance steady state concentration. Steady state concentration is the same thing as AUC, and that's a target concentration. So to achieve a given target concentration with a reduced clearance, you just reduce the dosing rate. And you can see that with this theoretical simulation on the left, that an increased dosing interval in patients with theoretical patients with renal impairment, where it's given every or twice a day as opposed to once a day, leads to a similar Cmax, maximal concentration, and a similar overall exposure. And so for concentration-dependent agents, it makes sense to just simply reduce the dosing frequency in order to maximize the peak concentration over the MIC. For time-dependent agents like beta-lactams, then just decrease the dose or the infusion rates to maximize the time over the MIC. And concentration-dependent agents, the best example is vancomycin, which I'll show you now. But remember, this is a clearance issue. And in critically ill patients, it doesn't matter what the renal function is, what the clearance is, you still need to give a loading dose, because the volume of distribution is increased in critical illness and is not affected by clearance. They're two independent parameters affected independently by different physiologies, or the same physiologies, but independently. And this is an important principle. So in a patient with renal failure, you still need to give the same loading dose, just reduce the maintenance dose, either in terms of frequency or in terms of dose. So vancomycin is the classic example of this, and we know that reduced vancomycin clearance due to reduced GFR could cause renal toxicity. Clearly, vancomycin clearance is related to creatinine clearance. This is just vancomycin concentrations plotted against creatinine clearance. Creatinine clearance is on the x-axis, and vancomycin clearance on the y-axis, a linear relationship. As creatinine clearance goes down, so does vancomycin clearance. And multiple studies, all observational, have shown that nephrotoxicity is related to trough concentration. So clearly there's a relationship between vancomycin exposure, there's a relationship between creatinine clearance, vancomycin clearance, exposure, and toxicity. This is a meta-analysis of 4 different studies, or a descriptive systematic analysis, review analysis of 4 different studies at different trough concentrations. And you can see as trough concentrations go up consistently in these different studies, the risk of nephrotoxicity goes up as well. Clearly, this isn't causal, because patients with higher vancomycin concentrations, that could lead to high exposures and therefore nephrotoxicity, but also patients with renal impairment getting vancomycin have higher vancomycin concentrations. The causal relationship hasn't been definitively shown, but I think it's very clear from observational studies and very consistent. And so as a result of this, guidelines recommend increased dosing intervals. Remember, it's a concentration-dependent agent in renal impairments, and we all have access to this and know this reduced dosing intervals, and that's the basis for it. And so I'm just going to end off to give some time for discussion. I don't know if I should, maybe I'll go through this quickly, to speak about therapeutic drug monitoring. because it's related to what I've been discussing already. And in this table, I've just summarized some of the some example antibiotics and some parameters that we think about when we think about applying therapeutic drug monitoring to a drug. So the parameters that would need to be in place in order for therapeutic drug monitoring to potentially be applied is if a drug has a high inter-individual variability, a narrow therapeutic range. Obviously, the drug has to have a defined exposure-response relationship. Otherwise, we don't know what to do with the therapeutic drug monitoring result that we get, right? And you do a concentration, you get a number back, but if you don't have a target, you don't know how to make a modification. And then obviously we only want to do therapeutic drug monitoring when we have evidence for improved clinical outcomes, either for efficacy or toxicity, when therapeutic drug monitoring is applied. And just to say that there's very limited evidence for any of this. So I'm not going to speak about this in more detail. If we have time after discussions, I can. Just to conclude then, so that we can have discussions, I think that understanding pharmacokinetics is important for antibiotic stewardship and for antibiotic prescribing in general for the work that we do. There are three primary independent PK parameters. That's bioavailability, which describes absorption, volume of distribution, and clearance. These are the basic principles. When there's an altered volume of distribution, then the loading dose needs to be adjusted. When there's an altered clearance, then the maintenance dose needs to be adjusted. The extent of steady state concentration is controlled by the dosing or infusion rate. The time to steady state concentration, not the extent, the time to steady state concentration is controlled by the half-life. The longer the half-life, the longer the time to steady state concentration. Therefore, a loading dose needs to be given to shorten that, and the opposite for a shorter half-life. And therapeutic drug monitoring may be useful for certain patients and drugs, which we can speak about if there's time. So, Jeremy, that's all. I'm very happy to have a discussion and take questions.
Thanks, Sean. That's amazing. Excuse me, as usual, a really, really great overview of some really important stuff. And I always find it's a pity it's not more in kind of teaching in really from med school upwards. I mean, there's some pharmacology, obviously, that's always done, but very little that kind of penetrates into FCP level and even into ID level to some degree. It's so important, as you suggested. I'm just going to go through some of the questions some people have sent through messages on WhatsApp and some in the chat there. So for the audience who do still want to ask a question, just type it in the chat. Makes it easy for me. Then I don't have to go between devices. Tom's asking about, just could you clarify what best predicts the therapeutic effects of vancomycin? He was mentioning, concentration dependent. And you're saying, but previously it's been said that area under the curve over MIC was the best predictor of effect.
Yeah. So, I mean, Tom, if AUC over MIC is the predictor of efficacy, which, by the way, hasn't been established, then that could be described as a concentration-dependent antibiotic, right? Because AUC is just the concentration over an average concentration over a dosing interval. It doesn't seem like the free time of drug over the time of drug over the MIC is important for vancomycin. I think what's much better established for vancomycin is the parameter, the PK parameter for toxicity, which is a trough concentration. Trough concentrations seem to relate to toxicity really consistently, and this cutoff of 50 milligrams a liter seems to be consistent. The efficacy target, AUC over MIC, is not established. Many different studies have found many different ones. The other problem is that in clinical practice, it's quite hard to estimate AUC. In fact, it's impossible at the bedside. You need multiple measures. I'm sure, as most people on this call know, you can use population PK models with very limited sampling from patients to estimate an AUC, and there are many calculators available for this. AUC thresholds have been published and are recommended. So I've seen an AUC threshold of 600, but this has not been validated in a randomized controlled trial. And so I think it's consistent to say, to answer your question, I think it's consistent to say that if an efficacy parameter of AUC over MIC is real, then that is a concentration dependent drug.
Yeah, thanks, Sean. So practically, like where, there are obviously some limitations to what we can do in our settings, but do you think some, we put up barriers a bit early sometimes as well? I mean, what's the practice like at, say, Groote in terms of vancomycin? Are you measuring trough levels for vancomycin, or are you measuring the sort of, there's a lot of talk about the new trapezoidal methods and things like that with 2 measurements being possibly better, but a lot more effort. We've struggled with it up here. And then things like, the minor glycosides as well. Is that also, how are you measuring drug levels currently in Groote, just to give an example?
Yeah. So for vancomycin, we're still doing trough concentrations. And again, that's really for toxicity monitoring, right? We don't do efficacy monitoring for vancomycin for 2 reasons. One is that it doesn't seem to be well predicted by trough. In fact, it isn't. I mean, the relationship between AUC and trough concentration is not, there's not a predictable relationship. And so you cannot use trough concentrations to say much about an AUC. And you can imagine all the reasons why, right? And so we're using trough for toxicity monitoring. Our pharmacology department has been looking into trying to get a system for 2 measurements and then translation into AUC for a long time, and they just haven't been able to get it together. I'm not sure if that is going to help us even, because again, I don't think the efficacy target is that well validated, and I would be reluctant to reduce if the trough concentration's okay and the patient doesn't have renal impairment, If you're giving vancomycin as a continuous infusion, which I'm not sure if your guys' ICU does that, our ICU does, then, once you're at steady state, which is very quick, you could just use the average steady state concentration to estimate the infusion rate if you know the clearance. I mean, you can just divide that, so you can take a concentration and you can just take a concentration and multiply that by 24 if you're giving it as a continuous infusion, and then you can get an AUC because the patient is already at steady state concentration. It's constant. And that's a useful way of estimating AUC without needing a population PK model. Also, it's a useful way of monitoring toxicity, right? Because, you don't need to wait for a trough. So they do that. I think that's useful, even though continuous infusions of vancomycin haven't been shown in studies to result in better outcomes. In terms of aminoglycosides, we do monitoring trough concentrations for toxicity. The efficacy target is better established than for vancomycin. And so you could take a peak concentration of an aminoglycoside and do therapeutic drug monitoring and do dose adjustments to try and achieve a better peak concentration. We do that sometimes, but not routinely. We mainly would go with troughs. And then again, like if it is elevated, we would increase the dosing interval.
Yeah, no, thanks. That's similar to here. I think, also with the extended infusions of the beta-lactams, I think, that we're often limited by really just the hardware of it, in terms of infusion pumps or some method of getting this even vaguely right. So it's often in our setting limited to sort of high cares and ICUs and much less in the wards. But
I think, look, for beta-lactams, I don't think there should be therapeutic drug monitoring. I didn't go into this in detail. Beta-lactams have a very wide therapeutic window. And so therapeutic drug monitoring is very unlikely to help. The other thing is that in critically ill patients, we know there's randomized control trial data to show that extended, prolonged, or continuous infusions save lives. And so therapeutic drug monitoring is not needed. Actually, what we should be doing is prolonged or continuous infusions. And I think, we've made a big effort to try and get that in place in our hospital at Groote, because it's just such a relatively simple intervention to reduce mortality.
Yeah, no, agreed fully. And that's kind of where I was going with it. That's been in some ways the frustrating part up here is the lack of a transition towards that in the general wards as well, which you can as you said, it's a pretty meaningful intervention. There's a mortality benefit in many instances, depending on the drug and the bug, but that's, as you say, much more important than therapeutic drug monitoring. It's interesting that even in the evidence, I actually wasn't aware of the therapeutic drug monitoring evidence that it wasn't good even outside of beta-lactams. I mean, fully accepting, obviously, beta-lactams have an enormously wide therapeutic window, so that makes sense. But for some of the other drugs which don't, you would think it would help. But I guess, I mean, do you think these, I mean, I don't know the evidence well. Is it sort of underpowered trials mostly, or do you think that just is not, like in 10 years' time, are we still going to be looking the same with therapeutic drug monitoring, do you think?
Yeah, I don't think it's been well enough studied. So, randomized controlled trials haven't been widely applied to like a TDM strategy. Also, I think it's difficult. One of the conditions, as I said, is that you've got to establish a PK/PD target. And it's not straightforward to establish that target. I mean, what target do you use? Do you use mortality? And then you think about, you get a concentration or a PK measure. And then, what's the output? Is it mortality? Is it time to blood culture clearance? Is it clinical cure? And if you think about, patients with infection, there's so many factors that go into those outcomes, not just the drug, right? The sickness of the patient, or, whatever, the other supportive care that they get. And so it's really hard to establish a target. That's why I think the evidence for toxicity is much better, because the toxicity outcome is easier to measure, right? So, I mean, it can be renal impairment, which is just one parameter, or it could be, like hemoglobin. So the evidence is better generally for toxicity targets and for therapeutic drug monitoring to reduce toxicity rather than efficacy. But I think that definitely people are paying more attention to this. I also think that the kind of integration of technology with easier measures of drug concentrations at the bedside will definitely improve this in the future.
Yeah, it's a great point. It's well put. Then just looking, there's a couple of questions about specific examples. I don't know if you able to answer this one, but it's asking about the practice of using loading dose of vancomycin in pediatric patients. I mean, presumably it's the same as adults. Obviously, the dose is different, but the concept's still the same in peds, I believe.
Yeah, I mean, it's exactly the same. I mean, look, I don't treat pediatric patients, but the PK principles, these are fundamental principles. It's identical. So if the volume of distribution is increased, then a loading dose should be given. And so in critically ill pediatric patients, a higher loading dose should be given for sure. I mean, the one thing to say about PK and pediatrics is allometric scaling. This is a kind of fundamental principle in nature, that the smaller the organism, the higher the metabolic rate. And it's exactly the same thing for drugs and for humans, right? So there's, kids have a higher intrinsic clearance of drugs than adults. And so the milligram per kilogram dose that's given in general, everyone I'm sure knows this, the milligram per kilogram dose in general is higher for kids than for adults. And, therefore the milligram per kilogram loading dose, I would assume would be higher. But I don't know specific dosing in kids.
Okay, great. And just one other question in the chat about dosing of some of the TB drugs with renal dysfunction. So they're talking about with low EGFR, we give ethambutol and PZA 3 times a week. What should we do if the patient's on hemodialysis? Because apparently it's dialyzed out. Presumably you just after the dialysis dose.
Yeah, you just dose the drug. I mean, so I'll kind of answer this more broadly. So in ICU, we get asked about ICU patients on continuous dialysis, and people kind of freak out. They don't know what to do. But continuous dialysis is just a kidney, right? I mean, it's just an external kidney that's causing clearance, elimination of the drug. And so you would just dose the drug normally. And so the same principle for intermittent hemodialysis, Jeremy, I agree. I mean, you would just dose after dialysis and assume that the GFR the next day is 0. The evidence for pyrazinamide reduced or alternate day dosing of pyrazinamide, I think, is less strong than ethambutol. So I really only do it for patients with really low GFRs. For thiamidol, I think it's reasonable because there's a clear relationship between exposure and toxicity, which is optic neuritis.
Great. Well, thanks very much. I think we're gonna leave it there. But that's again a real tour de force, and you've covered such important ground so ably. So thank you so much for your time and effort, and we appreciate that. And we will put the recording on the website eventually, so people who want to rewatch parts of it are able to. But thank you so much again, Sean, for all your time and effort.